Paul, just really quickly introduce yourself and tell everybody what you do and how long you've been doing it for.
Okay, I'm Paul. I live in Poland, in Warsaw. I'm 52. I turned this year 53, and I'm orthopedic surgeon. And I train with UMS for 1.5 years.
Yeah. Yeah, awesome. And you've been a spine surgeon an orthopedic surgeon for 20 years, yeah?
Yes, yes, I'm doing spine surgery for more than 20 years.
Yeah. Yeah. So pretty good person to talk to about back issues. So the Anuj, this is a really good opportunity for you because I think we can really add some value here. Can you clarify, Anuj, what it is that's been going on in your back that you joined the UMS? You got spondylolisthesis from what I remember. But yeah, it's, talk us through, Paul. I mean, if we're going to get value out of having you on here so that it's not just me talking. So somebody like Anuj who has spondylolisthesis, and when he started, he was in a lot of pain. If he deadlifted the wrong way, he would, get a real bad flare up and he'd have to take painkillers and he'd be on the couch. What has happened to get him? So he's doing the UMS. You know how the programming works. You know how the structural balance training works. What has happened in his body that's gotten him from the point where he was in so much pain to now where he can deadlift and he can do things and he lives a relatively pain-free life? What's gone on there?
Are you asking me?
Yeah, I'm asking you. Yeah.
Um, with the spondylolisthesis, there is a very huge component of instability of the spine. Because this is an injury of the parts which connects to joints or to different vertebra. So this part is injured, is fractured or genetically very weak. And there is a component of instability. So the instability makes a foraminal stenosis, which makes a compression of the nerve roots. So this is very common pain, which radiating to the buttocks, to the legs, down the legs, and lifting can increase this instability. So much important is to strengthen the muscles of your spine, and the general core muscles and lower body muscles. So deadlifting I think is one of the crucial exercise for improving your function with such a disease, such an issue in the spine.
Which is just incredible, isn't it, Paul? Because so many people have this experience where when they go to the gym and they try to deadlift, that it causes them pain, and so they think that the deadlifting is bad for them. So it's almost this paradox, isn't it, where people are like, I'm damned if I do and I'm damned if I don't.
Yeah, this is paradox because I was the same in the same situation. I thought that deadlifting is very dangerous for the spine, and but I didn't know I haven't know the proper technique of deadlifting. If you do it properly with maintaining the good the balance and the load is lifted directly vertically without any shifting in the front or in the back, and the muscle function correctly. So the lifting is very good exercise. So there is no if you do it progressive overload, there is no danger for the spine. On
Yep.
Yeah.
Yeah, 100%. And you know
Sorry, Rad. How do I look like? I'm
you
quite
look, man, you look really good.
discomfortable. I can't see myself. So
No, you look really good, man. I mean, have you got a laptop anywhere at home, anywhere nearby?
my laptop is occupied by my wife.
Yeah. Yeah, no worries. Yeah, you don't want to get in the way of her. Yeah, no, you look perfect, man. The picture is really clear as well. It's a really nice picture. So,
Okay.
yeah. I mean, look, the deadlift, because the way that it strengthens the entire body, you know, there's very few muscles that the deadlift actually doesn't strengthen. The only muscles that it doesn't really strengthen are the pushing muscles, because you're using your grip. You know, you use your grip. Which means that it uses the rotator cuff and the shoulder stabilizers. It uses the lats to pull the scapula down. It uses all the muscles down your posterior chain, so down your spine and the multifidus and the transverse abdominis, you know, all the muscles that are bracing. It uses the glutes, of course. It uses the hamstrings. It even uses a little bit of calves and even a little bit of quadriceps, because there is knee extension that goes on during the movement. So people always think of the deadlift as being an exercise for the glutes, and it is. It's definitely glute dominant, but you use more muscles in the deadlift than any other exercise.
Yeah, I was wondered that it was for me quite amazing, interesting that when I started to do deadlifting, and it was a few months ago with UMS, I felt my lats. I was very surprised. What's that? I feel my lats after deadlifting.
Yeah, absolutely. It does more muscles in the body than any other exercise, and it's such a shame that people get so afraid of it, because, of course, if it's done incorrectly, it can cause real problems. You know, it can be the thing you know, like if you already have a compromised spine, then deadlifting can be the thing that, you know, puts you on your ass and puts you into physiotherapy. And so people get really afraid by it. So talk me through this as well, because Anuj is on here and he said he's got L5S1 spondy and he's also got foraminal stenosis on the right side. What is stenosis?
Stenosis is narrowing of the space in the space in which are neural structures. So the spinal canal or the foramina, through the foramina, the nerves are going out from the spinal canal. So foraminal stenosis is the narrowing of this foramina, and the central stenosis is narrowing of the spinal canal.
Okay, and is that something that will ever improve, stenosis? Is that something that can improve without surgery, the symptoms of it?
It can symptomatically it can improve, because you know you cannot change the morphology without surgery. But as we said yesterday, you are not your morphology, the CT scan or MRI. You are what you are, with your symptoms or without any symptoms. So even if you have stenosis, there is with muscle stability, you can not feel any pain. Because of the stenosis. Yeah, there's still quite a lot of room for the nerve roots. There's a reserve. There's a reserve space for the neural structures, either for in the spinal canal or in foramina, neural foramina.
Yeah. So I want to get some clarity on something then, because stenosis is something that I only just learned about recently. And I've got the impression, the CT scan impressions here of one of our members who was asking me some questions. And there was a couple of questions that he asked me that I couldn't answer. And I never answer questions on something that I don't understand myself. I always say, look, you need to speak to somebody that knows this. But so this person has straightening of the cervical lordosis, modic type 1 end plate changes at C5, C6 and C6, C7. At C3, 4, disc bulge, mildly narrow the neural foramen, right greater than left. At C4, C5, disc bulge with uncinate hypertrophy resulting in a mild spinal canal stenosis and moderate bilateral neural foraminal narrowing. at C5, C6, disc bulge with superimposed.
Oh, man.
There's a lot, huh? All in the neck, yeah? Disc bulge with superimposed right foraminal disc herniation with ulcerate hypertrophy resulting in mild spinal canal stenosis and severe right and moderate left side neural foraminal narrowing. At C6, C7, disc bulge mildly narrows and neural foramen and multitunodular thyroid gland. So it's all stuff going on in the neck there. So that kind of, that kind of a diagnosis there, how severe is that? Because actually, you know what, hang on, Paul, just before you answer that. So there's that's the morphology. So for anybody that doesn't understand, that means that's what the scan says. His experience is that he noticed weakening in one side of his arms, and he noticed pain when he was doing certain exercises. And what I did with his training was I regressed him down to some structural balance training, exactly like what you're doing, and we reduced the load, and then we very gradually used progressive overload, and his symptoms started to subside. But he keeps coming back to me saying every now and then I'll try and do this and I get a bit more pain, and he's trying to understand whether these conditions are ever going to improve or if he's stuck with this and he needs surgery.
This what you have written,
read to you,
what you wrote, yeah. This is a kind of a radiologist madness. They describe anything they can see in the scans. So it's like writing that grass is green and sky is blue.
I love that you said that, man. I love that you said that. Keep talking. I can hear you. I'm just taking my jumper off. Keep talking.
Any spine surgeon, every spine surgeon has to analyze by himself the MRI. You look at the MRI and compare to the patient's symptoms, and you can't rely on the description by the radiologist. They write anything they see.
Yeah.
So this bulging can be 1 millimeter, 2 millimeter. It doesn't matter. If you don't have any symptoms, you can have on every disc bulging. This is not a big deal. What was that? Flattening of the cervical stenosis? Cervical lordosis?
Yeah, flattening of cervical lordosis. Yep.
Yeah, this is a kind of a reflect on pain. So the spine is protecting itself from the pain, so it stiffens up that way. So this can be in the lumbar spine, and the people with some pain can bend, walk with some bending, and the lordosis is also flattened. So this is kind of the pain reflex, yeah.
Yeah.
I would like to say that just in the summary of this, if you advise this guy to do workouts like in the UMS, any workout, the idea of workout is to grow muscle, and if you try to develop your muscle, the muscle will stabilize the spine, and any problems problems with morphology, some bulging disc, some instability, the symptoms can disappear with good muscle condition.
Yeah, I think that's so important, Paul, because Phil, you know who Phil is, right? The physiotherapist that we got on our shows sometimes. Have you ever seen him on our show before, on our stream?
Yes,
before?
yes. I love to listen to him, but he's speaking so quickly for me.
I know. A lot of people say
switch on the description.
A lot of people say that he's a very fast talker. So
I'm not English speaking. This is not my first language, so sometimes it's very difficult to understand what he's speaking.
Yeah, so he's been saying for years that you've got to really be careful when you look at an X-ray report, because exactly what you just said, they just write everything that they see, and it's written in these Latin terms that the average person doesn't understand, and it makes you look at it and just go, shit, I'm a complete mess. But it's not it's not always indicative of what the person is actually experiencing. Like when I got the MRI on my right shoulder, you know, I had the slap tear, I had a torn supraspinatus, I had a fluid in the bursa, and I had early onset of degenerative joint disease.
Everybody has fluid in the bursa.
Yeah, that's
everybody,
right.
Because this is
yeah, and everybody
no,
and everybody who's 47 who's been exercising for years has the early onset of degenerative joint disease. Everybody does. Like, it's just what
everybody. Yes, yes.
And
it's
so,
like we are aging. You have gray hairs, and you know.
Yeah, it's like the X-ray said, "Oh, you've got grey hairs on your head. You know, you've got to watch out for it." Yeah. So that's really refreshing to hear you say that, because I think a lot of people that are listening to this need to really be aware of that. Like that, you know, when you get your X-ray and you get your MRI, you really need to speak to somebody that can translate it for you, that can get you to understand what's going on, because the report is not intended for you. It's intended for a specialist, you know, to be able to look at. So, yeah. Yeah, so
yes,
you really...
exactly.
Yeah, no, sorry. You looked like you wanted to say something there.
No.
Yeah. So just to clarify and to sign off on this stenosis thing. So it's really something that that people can improve their symptoms on if they strength train and build muscle, and you know they're not doing it in a dangerous way.
Yes, you can improve the symptoms. Of course, there are some issues, some grade of the stenosis, which should be treated surgically. But especially you know if you don't have any neurological symptoms, there is this is the room for improving by exercises. If you have some neurological symptoms like neurological claudication, this is the situation that you walk, and after 10-15 minutes you must sit down because your legs are, you know, giving up, and or you have dropping your foot, or any other neurological symptoms. This is dangerous, and you need to think about surgery. But without neurological symptoms, if there is only pain, I know that pain can be very frustrating. I had a pain. I still have a pain in my hip, much less, but there is still. And I know that can be very frustrating, annoying, and you will do everything to relieve the pain. But if you have only pain, as far as there is no any neurologic symptoms, you can improve by exercises, and this is, I think, the best idea, and the best candidate for the good result with exercises and physiotherapy. But
great.
Mostly exercise.
Yeah. Great. Yeah, that's brilliant. So good to know. And I really hope that anybody that's listening to this that feels like they've had an MRI that was like a death sentence to them, because I know that feeling. You know, you've even had it yourself, Paul, where you x-rayed yourself and you look at the result and there's a part of you that almost feels like it's a death sentence. I really hope that for those of you out there that have got those MRIs and got those CT scans and are looking at this horrible diagnosis, that in the very least that this should really fill you with hope. And the thing that I would like everybody to really hold on to here is that what Paul's saying is the only time that you would really need to consider surgery as your first option is if you have nerve damage, or you're getting symptoms in the nervous system, like nerve symptoms. Is that right, Paul?
Yeah, and that's why I really don't like and don't propose patients to do MRI like you know, first choice of examination after a few days of pain in the back, even without radiating into down to the leg. because you need to have a time to recover, to heal it. Just wait for 6 weeks, and then if the symptoms are not improving at all or are worsening, you can choose doing MRI, but not after 1 week or 2 weeks.
Yeah, that's great. I really like that, Paul, because that also really aligns with what Phil says as well. And my advice to people whenever they have pain that they're unsure of is don't go to a doctor and get a referral to get a scan straight away. Go to a good physiotherapist, because
Yes. Yeah.
physiotherapists are experts at diagnosing you based on your movement and based on your perception of what's going on in your body. And then for somebody like me, where I can step in is I can help you to have the best chance of recovery once you have a diagnosis from a physiotherapist, because a physiotherapist will be able to say, you know, it's most likely that you're dealing with this, this, and this. So we want to avoid these movements and we want to strengthen these areas of the body. And then if that doesn't work and 6 weeks later the pain hasn't improved, then, you know, maybe you can consider going to get an MRI or something like that.
Yeah. Hmm.
Yeah. So Anuj is saying deadlifting with the right technique with feedback through the UMS has conditioned my body. Fear of deadlifting caused the muscular atrophy that created the spinal instability. Yeah, absolutely, Anuj. Absolutely. Look, Paul, I know it's late for you in the evening, man. So Anuj has said something
Yeah.
to you. Hang on, Paul, just before you go. Anuj has said, Paul, I've heard of some cases where exercise to establish more stability has resulted in reversing the forward shift of the vertebra. Is that possible?
Not exactly. It's you will not reverse this spondylolisthesis. It's rather impossible. I can't remember any such a case with reversal of spondylolisthesis. But you can stop it, and you can relieve the symptoms, and you can function with spondylolisthesis like you, Rat.
Yep.
Very well.
Yep. Yeah, in my personal experience, Anush, I have not been able to reverse it. That CT scan that you guys see me share, that was only done 18 months ago, so that's very recent. And the first time I was diagnosed with spondylolisthesis was in 2009 when I had my injury in the army. So I've been working to, you know, try to fix my spondylolisthesis for 16 years and I haven't been able to reverse it. But symptomatically, I'm completely pain free and I can do whatever I want, you know, like I'm a
That's
very
great.
capable
Yeah.
person. Yeah. Yeah. Man, thank you so much for your time again, and especially being so late at night for you. I really appreciate you jumping on, man, and it's always you know, really nice to talk to you. So thanks, Paul. Everybody on the stream, give Paul a big thanks for giving up his time to answer your questions and to give some clarity on some of this stuff. It's really nice.
Thank you very much, and it's always my pleasure.
Yeah.
And goodbye, good night. In my country, good night.
Yeah. Yeah. See you, Paul, and see you later, everybody. Thanks so much for tuning in. I'll catch you guys tomorrow.